This is the PARIS high flow trial. It is the Paediatric Acute Respiratory Intervention Study. My name is Geraldine Corcoran. I am the Central Nurse Educator for this randomised controlled trial, which we aim to demonstrate if high flow nasal cannula has a lower failure rate. And is there a need for a shift in paradigm in relation to oxygen therapy in the paediatric patients who have been diagnosed with bronchiolitis? The chief investigator for this study is Associate Professor Andreas Schibler, and he is part of the Paediatric Critical Care Research Group in Brisbane, and the study coordinator is Donna Franklin. So the research question that we are asking firstly is, what is the failure rate of an infant with bronchiolitis on standard hospital oxygen therapy in comparison to high flow nasal cannula therapy, and your standard hospital oxygen therapy being low flow oxygen? Secondly, if high flow is administered to the infant early in the acute phase of bronchiolitis, does this reduce down the need for transfer to an intensive care setting and reduce the patient's length of stay? Is the use of high flow in room air alone successful? And if so, is this early in the disease process or later? We have been successful in obtaining an NHMRC grant of $1.4 million for this multi-centre randomised controlled trial. We are aiming to recruit 1,400 patients over 3 years. Enrolled in this study, there are 10 Queensland regional hospitals and 7 predict sites, Townsville Hospital being one of those sites. So what is bronchiolitis? We know bronchiolitis is virus-induced. We know babies, particularly under the 12 months of age, admitted with bronchiolitis are the babies who have a high admission rate, resulting in 10 to 15% of these babies requiring transfer to a paediatric intensive care unit. And therefore this also causes a high economic burden on the health system. So what is high flow nasal cannula therapy? It is a continuous flow of gas that supplies the patient's resting minute volume. It reduces the work of breathing with positive pressure, similar to that of the CPAP. It is heated and humidified and helps to open the distal airways and alveoli. High flow also improves gaseous exchange. For the purpose of this study, the flow rate will be set at 2 litres per kilo per minute for the whole duration of this study. You will not be weaning flows, you will only be weaning oxygen. So who can be included in this trial? Infants who are less than 12 months of age, corrected, requiring admission to your hospital, who have a diagnosis of bronchiolitis. But also be mindful that if a baby is admitted to your ward with a viral illness or a reactive airways disease or asthma as potentials, these babies still have some similar symptoms to the babies presenting with bronchiolitis, in the fact that they have been unwell, off feeds, coughing, fever for up to 1 to 3 days, then worsening on day 3 to day 5 with increased work of breathing, and on auscultation findings of crackles and wheeze. These babies can also be included in the trial. If the baby has an oxygen requirement with SATs less than 92% in room air, they are included in the trial. So the 3 inclusion criteria are: the infant is less than 12 months of age, corrected, has a diagnosis of bronchiolitis, but to be aware of any other viruses that the baby has been diagnosed with, as they may actually be bronchiolitis as well, and the baby oxygen saturations are less than 92% in room air. If the baby comes into your emergency department via the ambulance, and the ambulance crew already have low flow nasal prong oxygen on the baby, then you can turn the oxygen off briefly to get a baseline as to what the baby's oxygen saturations are in room air. If the oxygen saturations are less than 92%, then you can enroll the baby into the trial. If the baby, however, comes into your emergency department and has been a retrieval from another hospital and has high flow oxygen therapy already on, this baby cannot be enrolled in the trial. Babies who are excluded from the trial are babies with upper airway obstruction, for example, laryngomalacia or choanal atresia, babies who have apneas, babies with craniofacial malformation, babies who are critically ill and require immediate intubation and ventilation or non-invasive ventilation. So the baby that comes into your emergency department and requires to be admitted to your resus area and who has moderate to severe work of breathing, and you're having to put the baby on high flow straight away, this baby is not the baby for the trial. This is your critically ill baby and will not be included in the trial. Babies with basal skull fractures, babies with trauma, babies with decreased level of consciousness, babies with cyanotic heart disease, and babies who are already on home oxygen therapy are also excluded from the trial. So how do we screen babies who are recruited to the trial? This is the study protocol screening chart in front of us here. And your baby firstly will have had a clinical diagnosis of bronchiolitis from your physician, and the baby will be less than 12 months of age corrected. As you can see on the box on the left hand side, this being the green box, that is the inclusion criteria that the baby must meet in order to be recruited to the trial, and we've already discussed this. If your baby's oxygen saturations are less than 92% in room air, then your baby already has an oxygen requirement, and we can recruit them into the trial straight away and randomize them into either the control, which will be your current hospital management, that being your low flow nasal prong oxygen, or into the high flow treatment arm. There will be envelopes in a randomization box, which I will talk a little bit more about in the next couple of slides. In that box there will be some envelopes, and you will pick an envelope out in sequential order, and in that envelope it's going to tell you which treatment arm your baby is going to go on. We have obtained delayed consent through the ethics department. It was felt that it was an inappropriate time to approach a parent in the emergency department when there is a lot of anxiety around the baby being admitted, and also being an inappropriate time to approach a parent in relation to obtaining consent. Therefore, we can obtain delayed consent, that meaning we will be consenting these parents on the ward, and we have up to 24 hours to obtain consent for this study. That means you can go ahead and randomize the baby into the trial, and whichever treatment arm the baby is randomized to in that envelope, you start that treatment and consent will be obtained up on the ward. It was also felt that it was minimal interference in relation to the baby's care in regards to these two therapies. There was minimal risk involved in both of these treatments. Therefore, delayed consent for up to 24 hours was successful in being granted. If the baby, however, is admitted to your department and requires admission to the ward, and however does not have an oxygen requirement as yet, that meaning the baby's oxygen saturations are greater than or equal to 92%, and the physician feels the baby is still too unwell to be discharged home, and the baby is admitted to the ward, to the paediatric ward, and say, for example, the baby fell asleep and the oxygen saturations decreased to less than 92%, you on the ward can enroll the baby into the trial, and that is a matter of the registrar getting the randomization envelope downstairs in the emergency department, and I'll talk a little bit more about that later. The box on the right hand side is the list of the exclusion criteria, which we have previously discussed also. The study material provided, this is an example of our randomization study box, and on the outside of it we have orange coding for all our study material. It says Paediatric High Flow Study. In that box there is randomization envelopes. In that large envelope you will see there's a study number in the front of the envelope, and in that envelope there is a smaller envelope with some stickers telling you where they need to be put. And also it's important that we randomize using sequential order when taking out the envelopes. Here is an example of the randomization envelopes. This example is showing you in the inside of the small envelope, it's got the study number, the patient got control, another study number lower down with a patient on high flow. And these can be stuck and adhered to the front of the patient booklet. The patient booklet stays with the patient at the bedside for the whole admission. In that randomization box, these are the patient booklets, envelopes that you will see in the box. In that envelope is your patient booklet, and you will see that in the front of the small envelope that you will have in relation to which treatment arm the baby received, there will be some stickers that you would adhere to the front of that patient booklet, and also the patient's UR number. And that patient booklet stays with the patient for the full admission and is situated at the bedside in the patient's folder on the ward. So from emergency department, that patient booklet will go with the patient and their clinical notes up to the ward. For the baby who gets randomized to the control treatment arm, this is your current hospital management of low flow nasal cannula oxygen 0 to 2 litres via the nasal prong. In regards to this protocol, you will apply the nasal cannula to the baby, aiming to give them the minimal amount of oxygen possible, 0 to 2 litres per minute, and aiming for an oxygen saturation between 92 and 98%. We know there will be responders to this treatment arm, and the responders are shown on the box on the left hand side. We know from clinical parameters based on a pilot study done previously that a baby will respond to this treatment once their heart rate reduces, respiratory rate reduces, and you're needing less than 2 litres of oxygen to maintain the baby's oxygen saturations greater than 92%. However, you will have non-responders to this treatment arm as well. And if a baby meets 3 out of the 4 criteria on the box on the right hand side, it means this baby is not improving with the treatment that they are currently having, and we will have to escalate their care. Again, from the pilot study, we know that if a baby's heart rate remains unchanged or is increasing, their respiratory rate remains unchanged or is increasing, your acute early warning tool is triggering a medical review, and or you're needing greater than 2 litres of oxygen to maintain the baby's oxygen saturations greater than 92%. This baby is a non-responder and not responding to the treatment currently given, and you would have to escalate care and administer high-flow nasal cannula treatment. We do say to wait a while and not transfer quickly and escalate care from control to high flow unless you see a pattern occurring. We're advising to adhere to the study protocol closely and allow for at least 3 hours or more before escalation of treatment. However, if you are concerned about your patient, please absolutely do the necessary. When the baby is escalated to the high flow treatment arm, the baby still remains in the study. If the baby gets the high flow treatment arm, we're looking on the right hand side of the flow chart. We will start the baby on high flow in room air first for the first 10 minutes and document their observations in that time. If the baby's oxygen saturations are between 92 and 98%, the baby can stay on room air for that duration of the treatment, and you would go into the weaning protocol in relation to the next step. If the baby, however, oxygen saturations did not improve, you would add oxygen on to the Airvo machine until you got the oxygen saturations between 92 and 98%. And obviously the baby will be requiring the minimal amount of oxygen needed. However, we know there will be non-responders to this treatment also, and we know this, that a baby will display a non-responder criteria if they made 3 out of the 4 criteria in the box on the left hand side. One of those criteria being if the baby's oxygen requirement is greater than 40% to maintain the baby's oxygen saturations between 92 and 98%, then the baby is failing in that treatment arm, along with their showing signs of unchanged heart rate, respiratory rate, and your early warning tool is triggering a medical review. You would contact your paediatric team and request a referral. On the left-hand, on the left-hand side, we would only look at this side of the flow chart. If a baby was on the control arm and you had to escalate care to the high flow treatment arm, we would use this side of the flow chart. We would be basically bypassing putting the baby on high flow in room air because we already know the baby has an oxygen requirement. So we would be concentrating on this side of the flow chart. Also, babies who are randomised to the high flow treatment arm with an oxygen saturations less than 85%, they would be using this side of the treatment arm as well. In regards to weaning and titrating the oxygen, once the patients who are responding to the high flow with oxygen, once their oxygen saturations are greater than or equal to 92%, you can wean or reduce the oxygen by 5% steps at regular intervals. So if your patient was on 30% oxygen, you would wean, and their oxygen saturations were greater than or equal to 92%, you can wean the oxygen down to 25%. At regular intervals, that means if you come in to the patient's cubicle an hour's time or in a half an hour's time, and you see that their oxygen saturations are greater than or equal to 92% again after weaning down from 30 to 25%, you can wean further, and therefore you would be weaning down to your room air 21%. If the patients are maintaining their oxygen saturations between 92 to 98% for more than 4 hours on high flow and room air, then you can cease the high flow. Remove the nasal cannula. You can leave the wiggle pads on the baby's face and allow the patient to breathe normally in room air with no high flow. You will leave the Airvo2 machine beside the patient just in case the baby decompensates at a later stage when they fall asleep and their oxygen saturations drop again to less than 92%. And if that was to occur, you would put the baby on high flow again, but in room air, still on your same settings at 2 litres per kilo per minute, because the machine will remember your previous settings. And you would override the disinfection signal that would come up on the screen. You would just hit the mode button to override the yellow, the amber light, because this is still going back on the same patient on the same admission, so there's no need to do a disinfection cycle. Again, you would monitor the patient after 10 minutes in room air on 2 litres per kilo per minute to see if that was enough to improve their oxygen saturations to greater than or equal to 92%. If not, then you would add oxygen and you would start the whole cycle again. Fisher & Paykel will be supplying Airvo2 machines for this study. For Townsville Hospital, you will receive 5 Airvo2 machines. Ideally, 4 of those will be kept in your ED department and 1 on the paediatric ward. The picture on the right hand side shows a baby on the Airvo2 machine, most importantly with the circuit away from the baby's skin. All of the machines for the trial will default to junior mode, and you will be able to apply 2 types of oxygen nasal cannula to the baby on the junior mode, that being the paediatric and the infant nasal cannulas, both symbolised by the green bird and the purple butterfly, and this is reflected on the display screen on the Airvo2 machine. If your baby gets randomised to the high flow treatment arm in the emergency department and you need to transfer the baby to the paediatric ward, there will be some oxygen transport tubing supplied with the consumables for this study. This oxygen tubing has got an adapter at the top of the oxygen tubing that you basically apply straight into the OptiFlow nasal cannula. You will disconnect the circuit of the high flow, attach the adapter of the green OptiFlow oxygen transport tubing, and deliver dry oxygen to the baby on transfer from ED to the ward. The Airvo 2 machine, you will wheel all of that with the circuit that you've already opened up to the paediatric ward, and then you will switch the machine on. It will remember the last settings that you entered in, being the baby's weight at 2 litres per kilo per minute. And you will get an amber light come up saying the machine needs to be disinfected. Ignore this light because this machine is going back on the exact same patient that already came off the machine and the same circuit. You can override this by pressing the mode button and it will automatically go into the junior mode itself. In regards to delayed consent, I just touched on this previously. Who can consent? The parents. It can be consultants, it can be registrars, it can be your research assistants, it can be your champion nurses, and it can also be your senior nursing staff. And how do you consent a parent to the trial? Well, currently the hospital management for bronchiolitis consists of 2 different oxygen therapies, which are both safe and often randomly used. And their child has been randomly selected to one of these treatment arms. And the study team would like to collect the data on the treatment arm that their child has been placed on. Sometimes we get questions from a parent or guardian as to which treatment arm would you choose or what do you think would be the best treatment for our baby. And our response to this has been, we cannot provide an answer to this as we do not have any evidence to support which treatment is better. And this is why we are doing the study. We need to scientifically prove that high flow is more superior to our standard low flow oxygen therapy. And this is why the data collection is important. So, important things to remember for babies who are on the high flow nasal cannula study. An NG tube is mandatory to be inserted on babies who are on the high flow treatment arm. It has not been proven to be safe to give babies high flow with oral feeds. We must veer on the side of caution and give babies continuous or bolus feeds during the high flow treatment. There is a section in the patient booklet that refers to feeding, and there is an area there when the baby is in the weaning phase that you can wean down your oxygen on the high flow to 2 litres and increase your oxygen to 100%, giving humidified low flow oxygen for a maximum of 20 minutes. That's only for babies who are improving or in the weaning phase and for babies who are breastfed babies and need the comfort feed. Please refer to the patient booklet for this information. We've already talked about delayed consent. We've already mentioned that flow must remain at 2 litres per kilo per minute at all times. And also importantly that the first set of observations documented on the bronchiolitis acute form shows that the baby's oxygen saturations were less than 92%. This demonstrates to us that the baby had met the inclusion criteria and therefore adhered to protocol. It's also important to document in the patient's booklet date and time of commencement of the treatment. However, in the emergency department, we know you are time poor, and even if you document this in the intervention section in the front of the acute chart, this will be really appreciated. Nursing acuity should not change from your normal practice of caring for patients on standard oxygen therapy. In regards to this, we refer to babies who are treated on the high flow treatment arm. Their acuity of care should not change as they are not your sick babies. These are your mild to moderate work of breathing babies who ideally may have been randomised to the control arm. Therefore, they should be treated accordingly in regards to nursing acuity. Team to contact for any questions in relation to this study. At your hospital in Townsville, your research assistant is Monty. Your principal investigator is Dr. Jeremy Furick, who is based in the emergency department. You will also have nurse educators in your emergency department and paediatric ward, and also your nurse champions in emergency and the paediatric ward. All of these people will be a resource to you for any questions you may have. However, please be mindful as well, we, the Central Study Team in Brisbane, are available 24/7 should you have any questions in relation to the study. Our contact details will be on signage in the department once you go live with the trial. For you at Townsville, will have one randomisation box. This will be situated in your emergency department, in your fast track fishbowl. In that randomisation box, there will be patient booklets, and there will be also a bronchiolitis acute form in that patient booklet also for you to commence documentation of the baby's observations. We have adapted your normal acute tool into a bronchiolitic acute form for the purposes of this study. You will also, in relation to your Airvo 2 machines, you will be returning those to Bs when they are finished with on the ward. We will also have nurse champions for this study, and we will soon put out an expression of interest for champions who we are looking for to really drive this study. As we are based in Brisbane, we need you on the floor really driving the study and reminding staff about babies who meet the inclusion criteria that they are enrolled into the trial. We provide a champion resource package for champions who are interested and express their interest in being involved in the trial. We provide a lot more physiology and some research articles, and also a little bit more about consenting.